So without further ado, research to practice, Samuel Rubinstein, MD, Management of Multiple Myeloma updates. And we've got a brief bio there, but I want to say welcome to Dr. Rubinstein. Thank you so much for joining us.
And thank you so much for having me. I'm not going to go through my bio in that much depth, but basically the Cliffs.
Oh, go ahead.
The Cliffs Notes is I'm a myeloma focused and plasma cell dyscrasia focused clinician and clinical researcher here at UNC, or not here at UNC. Here is my house, but I work at UNC. So we got some poll everywhere questions throughout this presentation. As Tim was mentioning, I structured this so that they're mostly prompts for the next set of slides. They're not intended to quiz. Any of you guys know, you talk to 3 myeloma docs, you get 5 answers. So there is not really a right answer for most things in managing multiple myeloma in 2024. The idea is to get juices flowing, so don't feel like it's a test.
Sounds good. And I'm just going to flash up our disclosures real quick because we do need to show those. But thank goodness we don't have to read those anymore. But I'm just going to pop those up so that everyone can see those. And then I'm going to go back and let's look at that. So multiple myeloma is a cancer that forms in a type of white blood cell called a plasma cell. Looks like there's a pretty strong tendency towards the true answer. How are they doing, Dr. Rubinstein?
I'd say they're doing pretty well.
Great. Well, I'm going to get to that first slide and get out of your way. Management of multiple myeloma updates, and I'll turn it over to you. Thanks so much.
Fabulous. Thank you so much. So thanks, everybody, for your attention. Those are my disclosures. I will be talking about some agents that are made by those sponsors, but I promise to be fair and balanced. So the objectives today are to discuss current management of patients with multiple myeloma in a variety of contexts. I'm going to take you guys through recent updates, trials updating and informing the management of patients with newly diagnosed multiple myeloma, both eligible and ineligible for stem cell transplant. And then I'm going to discuss management of relapsed myeloma, breaking it into strategies for managing earlier and later relapses. So first polling question, a 55-year-old male with no past medical history develops new onset back pain. An MRI of the lumbar spine reveals an enhancing 3.5 centimeter lesion in his L3 vertebral body. A marrow biopsy is ultimately done and reveals 20% plasma cells. Cytogenetics reveal a gain of 1Q, but no other abnormalities, and all of his labs are normal. Induction regimen of choice, RVD, or lenalidomide, bortezomib, dexamethasone, daratumumab, RVD, daratumumab, RD, or other.
All right, and I'm just going to advance to that next slide so we can see those results as they come in.
Okay, looks like we have a stable-ish plurality or a majority for RVD and a plurality for DARA-RVD. And then a few people recommending DARA-RD. Okay, so the first question when you're faced with managing newly diagnosed myeloma is to transplant or not to transplant. The patient in the prior question, the idea was that that was somebody who should be eligible for stem cell transplantation if it's consistent with their goals of care. But the question is, if somebody's eligible in 2024, do we transplant or do we not transplant? That's really the first fork in the road when you're deciding how to take care of somebody. So historical data prior to determination, which is the latest trial informing the question of transplant or no transplant, basically the 2 pivotal trials that answered this question were IFM 2009 and EMN 02. IFM 2009 is a French trial in which patients were randomized to get RVD alone for 8 cycles, or RVD for 3 cycles as induction, followed by stem cell transplant, followed by 2 consolidation cycles of RVD. This is a trial most people here are going to be familiar with. And this trial showed a little over a 1-year advantage in progression-free survival for patients who underwent frontline transplant. More compellingly, it showed about a 50% increase in the likelihood that somebody remained disease-free 8 years after diagnosis. Critically, despite this meaningful difference in progression-free survival, there was no difference in overall survival between arms, including at a recent update with 8 years of median follow-up. EMN02 randomized patients who got no Revlimid-based induction, so Cyborg-D, to either get VNP as consolidation or bortezomib, melphalan, prednisone, or stem cell transplant. This trial also corroborated about a 1-year advantage in progression-free survival and did show a modest improvement in overall survival at about 6 years. So these are the curves showing progression-free survival and overall survival on IFM 2009. We see the patients undergoing transplantation have a meaningful increase in their probability of being progression-free at up to 4 years out from diagnosis. However, that did not translate into an advantage in overall survival. So why recommend ASCT with these data? Delaying progression is not going to be as important as living longer or living better to most patients. So for one, transplant in both of these studies has a consistent advantage in PFS1, which is a goal in and of itself. Most patients want myeloma as firmly in the rearview mirror as possible, and so delaying progression is compelling for a lot of our patients. Furthermore, we had concerns that the null overall survival result didn't apply. These are French patients who tend to live healthier lifestyles and live longer than our patients in the United States, which translates into a majority of those who did not get frontline transplant being eligible at relapse. Certainly, this is not the case for most of our patients here in the United States. We meet them a little bit later, and usually it's now or never. The median age is a bit young, about 10 years younger than the typical age of a newly diagnosed myeloma patient in the U.S. And more critically, the practice pattern does not mirror what we do in the United States. IFM 2009 only used 1 year of lenalidomide maintenance and did use post-transplant consolidation. So data mirroring the U.S. practice pattern are needed, and this is where the determination trial came in. This trial randomized patients after receiving 1 cycle of RVD, 1-to-1, to get an additional 7 cycles of RVD, or to get a similar paradigm to the treatment arm on IFM 2009, which is 2 more cycles of RVD, transplant, and then 2 cycles as consolidation. The consolidation piece is conserved, but unlike IFM 2009, patients on the determination trial got Revlimid indefinitely, which is generally our default for how we administer post-transplant maintenance in the United States. Key points about the patient population. Median age is 56, remains a pretty young population. Nobody over the age of 70 gets on either of these trials. Similar proportions of important subgroup of interest to general U.S. myeloma population, about 1 in 5 with high-risk cytogenetics, a representative racial and ethnic makeup of patients with multiple myeloma to our panels. And then half the patients had ECOG PS of 1 or greater, so there was some functional impairment in this population as well. Post-protocol, only 28% of patients were able to get a transplant at relapse. This mirrors a little better our experience in the United States than the French study does. And most patients were salvaged with a modern regimen containing at least a PI or an IMiD, although the agents that we most commonly use in early relapse, so daratumumab and Kyprolis or carfilzomib, were relatively underutilized. So this trial has a similar theme to the IFM 2009 study in that it showed a meaningful delay of progression-free survival, but despite the fact that most patients did not get transplant at relapse, there remained no benefit in overall survival. What about quality of life? Living longer is important to most patients, but living better is also important to a lot of patients. So this trial shows what anybody who's taking care of a transplant patient would know, which is that during the transplant itself, we see a meaningful drop in the quality of life. Over time, the quality of life for transplanted patients improves and reverts back to baseline by 3 cycles of therapy post-transplant. And in the long run, has a non-significant trend towards being better in people who underwent a stem cell transplant. So it's an investment for long-term, at least reversion to baseline quality of life, potentially better. What about high-risk patients? These are people we conventionally think as needing more aggressive therapy. They had an even more impressive progression-free survival advantage than those who had standard risk myeloma, nearly median progression-free survival nearly tripling in high-risk patients who underwent a stem cell transplant with a hazard ratio of 2. So how does this inform my practice? I continue to recommend all eligible patients consider autologous stem cell transplant. This trial, I think, still shows that even with a U.S. practice pattern and indefinite Revlimid maintenance, a frontline transplant meaningfully delays progression. PFS1, I think, remains meaningful in and of itself. We'll talk about relapse strategies later, but as many of us know, relapse myeloma treatment patterns generally involve patients being tethered to the infusion center and getting treated with more intense regimens. People don't like that. So prolonging maintenance on single-agent Revlimid is a primary benefit to a lot of patients. In particular, transplant is important for folks with high-risk disease. However, the null overall survival result with relatively few patients getting transplanted salvage does introduce some more equipoise. So I think whereas previously transplant was a very strong recommendation, now it's a recommendation that leads to a bit more of a bidirectional discussion. So factors in considering who's eligible for transplant, obviously performance status is key. Determination does show that even patients with some functional impairment derive benefit from stem cell transplant. Patients need to have adequate social support to undergo temporary relocation and have a caregiver who's able to bring them to a transplant center should they have toxicity. And then, of course, there are limitations imposed by patients' comorbid medical conditions. And as previously discussed, myeloma risk plays into how strongly we make the recommendation as well. So we're going to discuss induction approaches for patients that have newly diagnosed myeloma first, and we're going to first focus on those who are eligible for autologous transplant. So this is a summary of a variety of recent trials, and with the exception of determination, which we've just spent a good amount of time discussing, most of these are trials comparing an anti-CD38 monoclonal antibody plus X versus X. And the theme that emerges is by adding a frontline CD38-directed monoclonal antibody, or anti-CD38 for short, what we see is pretty dramatic improvements in progression-free survival. So the Cassiopeia trial done in Europe randomized patients to bortezomib thalidomide dex or bortezomib thalidomide dex as a millennial. Despite being a myeloma, very busy myeloma doc, I have never written an order for thalidomide. Not the easiest drug to give, obviously. But in that context, daratumumab frontline meaningfully delayed progression and improved depth of response. More relevant to the U.S. practice pattern, we have Griffin and Perseus, which are two randomized trials comparing daratumumab RVD to RVD alone. Both of those trials demonstrate a meaningful improvement in progression-free survival at 4 years of follow-up, with the probability of progression being cut in half or more with frontline daratumumab. And then the Ischia trial is relatively early in its follow-up. That trial focuses on patients with higher risk phenotypes of multiple myeloma, uses isatuximab KRD. Still early and not yet a PFS advantage, but there is a meaningful difference in the probability of achieving minimal residual disease negativity. What about toxicity? Obviously, there's no free lunch in medicine. And certainly the CD38 monoclonal antibodies are no exception, but the increases in toxicities that we see by adding a CD38 monoclonal frontline are relatively modest. So the theme that emerges is you do get about doubling of the rate of grade 3 neutropenia when you add a CD38 drug. Notably on the Perseus trial, which is the biggest and best of these trials, in my opinion, we don't see such a big increase in the probability of grade 3 neutropenia. And then you have modest, usually non-significant increases in the probability of infection. Again, Perseus gives us the biggest data point, where we have 35% of patients with some grade 3 infection getting the quadruplet, and versus 27% on the triplet, and then 10% versus 6% are getting pneumonia specifically. I'll also draw your attention to the infusion reactions. Obviously, when we're counseling patients about CD38 drugs, we talk to them about the probability of infusion reactions. These are very rarely severe enough to require hospitalization, which is what a grade 3 infusion reaction means. Less than 1% of patients on the experimental arm of Perseus needed hospitalization for an infusion reaction. So moving on, this is a little deeper dive on the Griffin trial. So Griffin trial and Perseus trial are two very similar trials, although Griffin is a little bit smaller and uses a somewhat more intensive schedule of induction. So what these trials did is they randomized patients to the classic twice-weekly Velcade schedule of RVD, plus or minus daratumumab. Daratumumab was given weekly for a total of 4 3-week cycles on the treatment arm, and then after transplant was given weekly as well. Following the completion of 6 cycles of induction and consolidation in aggregate, patients that were randomized to get Dara and induction also got daratumumab and Revlimid for a total of 2 years versus Revlimid alone on the control arm. Both arms went on to single-agent Revlimid following completion of 2 years. So what this study showed is that by adding daratumumab frontline, we get meaningful improvements in the probability that patients are achieve stringent CR at some point, 63 versus 45%. And then MRD negativity rates, which we'll talk about, are increasingly salient in picking induction regimens, more than doubled for patients getting frontline Dara. PFS, as previously discussed, started to separate around 2 years, and at 4 years of median follow-up, almost 90% of patients getting the quad are Dara RVD are progression-free. Perseus, bigger version of this trial, did adjust the schedule slightly, although patients still got twice-weekly Velcade on this trial, which, of course, may not be what all of us do in our real-world practices, but the cycle length was 28, so they at least got 2 weeks off between cycles. Just as Perseus did, split up the quad into 4 cycles prior to transplant, 2 cycles after, and then gave daratumumab and Revlimid maintenance for a total of 2 years. Patients who achieved MRD negativity on this trial were able to stop daratumumab. Those who did not stayed on it. Very similar advantage in progression-free survival. Greater than 5 in 6 patients progression-free at 4 years on the Dara RVD arm versus about 2 in 3 on the RVD arm. So nearly doubling, more than doubling the probability of being progression-free at more than 4 years of median follow-up. What about response depth? The longer patients stay on both regimens, the higher the probability is that people achieve complete remission. Nearly 90% of patients on the Perseus trial eventually achieve complete remission versus 70% of patients getting RVD. As far as MRD negativity goes, also a meaningful improvement in the probability of achieving MRD negativity for patients getting frontline daratumumab, 74% versus 47% on the RVD arm, and then those experiencing sustained MRD negativity, so staying getting MRD negative and staying there, which may be a more relevant surrogate for how well and how long folks are likely to live. Nearly 2 in 3 patients getting the quadruplet regimen, sustained MRD negativity for a year, and then nearly 60% for more than a year and a half. So these represent dramatic improvements in terms of what's seen in the antecedent standard of care, and all for a relatively modest increase in toxicity. So do we need to apply the same strategy for all patients? With the modern era, what we've seen is that with Dara RVD, a transplant, and then maintenance afterwards, greater than 90% of patients are not progressing at 4 years. This is a quite intense bundle of therapy. So a very open and active question is, can we adapt our therapy either in intensity or duration to depth of response and risk stratification? We're not doing this yet, but I'm going to show you some intriguing data that suggests the ball may be headed there in the future. This discussion, is going to dive a little deeper into the role of minimal residual disease negativity. So for those unfamiliar, minimal residual disease negativity refers to methods of detecting really any hematologic malignancy below the depth of conventional hematopathology assessment and imaging and blood work. So there's many methods to do this in multiple myeloma. The one that is FDA approved is a method that's based around next generation sequencing, looking for dominant clones of myeloma at diagnosis and then detecting at a sensitivity of 1 in 10 to the 6, so 1 in a million bone marrow cells, how many are residual myeloma at any time point. So the studies that led to this being utilized were based around this meta-analysis that's reported here. So this is published a few years ago in Blood Advances. Nicole Munshi from Dana-Farber combined a number of frontline myeloma studies, including IFM 2009 and the SWOG 777 study, which I'm not talking about here, and compared the progression-free and overall survival of patients who achieved MRD negativity and those who did not. And what has been found is that those achieving MRD negativity have dramatically better probability of delayed progression, both those eligible and ineligible for transplant, and then those achieving MRD negativity enjoy longer overall survival than those who don't. So clearly a very powerful prognostic tool, can identify patients that are much lower risk to have an adverse outcome. This distinguishment improves with depth of MRD negativity, having fewer than 1 in 10,000 myeloma cells is good, but it's not as good as having fewer than 1 in a million. That may be obvious, but still good to show it. And then the prognostic utility of MRD negativity is preserved whether patients have high risk or standard risk phenotypes of multiple myeloma very critically. So how is this being applied in prospective studies to try and modify the long-term treatment of patients with myeloma? So this is one of my favorite ongoing myeloma trials. This is the MASTER trial, which is being led by my colleague Luciano Costa at the University of Alabama, Birmingham. So this is a phase 2 study with an enriched cohort for patients with high-risk subtypes of myeloma. So patients with translocation 414, 1416, and deletion 17p accounted for more than a third of the population in this study, which is greater than the proportion of those patients in a general population of people with myeloma. So they gave all these patients a quadruplet, daratumumab, carfilzomib, Revlimid, Dex. All patients went to transplant, and then MRD was assessed following completion of all of these time points. And patients getting MRD negativity twice in a row were able to come off of therapy. So if a patient got Dara-KRD, autologous transplant, and is MRD negative both of those time points, they stop. Subsequently, MRD negativity was assessed after 4 cycles of consolidation. Patients remaining MRD positive after 8 cycles total of consolidation got another 4, and then all patients who remained MRD positive went on maintenance. And so what this trial shows is that even patients with one high-risk cytogenetic abnormality had relatively high rates of progression-free survival up to 3 years follow-up, even stopping therapy after just 4 cycles of induction and a transplant. And the vast majority of these patients with 0 and 1 high-risk cytogenetic abnormality remain alive at 4 years of follow-up, greater than 90% overall survival. So lower than the Perseus data, but I'll draw your attention to the fact that very high percentages of these patients have higher risk types of disease. Folks with 2 high-risk cytogenetic abnormalities did not do as well. Those are probably not patients who can stop therapy, but this is, to me, intriguing proof of concept that the therapy that we have now is good enough that we may be able to stop therapy in a subset of patients with not the highest risk phenotypes of myeloma who are able to achieve deep remissions. More to come on this point. I'm not yet doing this in my standard practice, but I'm eagerly watching this trial. I firmly believe the greatest unmet need in myeloma therapy is stopping therapy. More data showing more or less the same. So that's the transplant-eligible population. That's nice to know we're making progress for the 1 in 3 patients that can get a transplant. What about the majority of patients who are not eligible for stem cell transplant? All right, so a 75-year-old male with hypertension, well-controlled diabetes, and heart reduction, congestive heart failure with reduced EF, stable, develops new onset back pain. He has a 3.5 centimeter lesion in his L3 vertebral body. A marrow biopsy reveals 20% plasma cells. He has gain of 1Q, no other abnormalities, and the remainder of his labs are normal despite that medical history. Induction regimen of choice, lenalidomide dex, lenalidomide bortezomib dex light with once weekly Velcade, daratumumab lendex, isatuximab RVD, daratumumab RVD, or other. I'll call attention to the fact that I've tried to give you somebody that is not likely to be eligible for transplant. Okay. So I think we have a stable consensus that most people would try to give this patient a quadruplet. Some would still give RVD light, and then 3% of patients would give DARA-RD. Or of participants, sorry. I guess all of us are patients, but not with respect to myeloma, hopefully. Okay, so these are data showing the evolving standard of care for transplant ineligible patients, and it has a similar theme to the evolving standard of care for eligible patients, which is that a lot of emerging data supports using a CD38 as part of the frontline regimen. So the Maya protocol was published now over 5 years ago, compared DARA-RD to RD, showed a significant improvement in progression-free survival, which I'll show you later has translated into improvement in overall survival. More recently, at this year's ASCO meeting and synchronously published in high-impact hematology journals, we had the MROS and benefit trials that looked at isatuximab RVD compared with two different triplet regimens, RVD or ISA-RD, with both trials suggesting some benefit to the quad over the triplet. MROS showing improvement in PFS and MRD negativity with ISA-RVD versus RVD benefit, which has smaller and shorter follow-up, showing improved depth of response, but a non-significant improvement in PFS. As with the transplant-eligible population, the investment that one puts in for this improvement in toxicity is primarily a small, modest, real, but not significant improvement in the, increase in the rate of infections. So the quadruplet regimens result in about 5-10% more grade 3 infections. I'll draw your attention as well to the benefit trial, which unlike most of the other trials I've talked about, is not CD38X versus X. It's ISA-RVD versus ISA-RD. So the question I struggle with a lot in the transplant ineligible patients is whether to use bortezomib or not. And benefit, interestingly, is a Rorschach test for this. You can decide how you feel and use it to support whatever you'd like. It does show that the probability of a grade 3 sensory neuropathy, which if you look at the CTCAE, that's very severe debilitating neuropathy, unlikely to result in functional recovery, that probability triples. So 27 versus 10% of patients are getting grade 3 neuropathy with adding bortezomib to frontline management for somebody who's not eligible for stem cell transplant. So when we talk about the benefits that are seen on benefit, keep in mind that that's the price that you pay. Maybe a little different calculus than the other trials we've discussed today. So looking at the Maya trial, this is a trial that, as I mentioned, is quite mature. It now has mature 7-year overall survival rate. Pretty remarkably, patients on this trial who did not undergo stem cell transplant, who were randomized to get DARA-RD frontline, a majority of them are still alive 7 years after diagnosis. So very impressive result and a clear improvement in overall survival over patients getting doublets. If a patient is frail and you're concerned about giving full intensity therapy, I think these data are compelling enough to suggest that instead of deferring a drug, you should probably be trying to give an attenuated version with lower dose lenalidomide. Overall survival advantages, in my opinion, are very hard to ignore. And then most patients had not, at 7 years of follow-up, required to get a different regimen other than DARA-RD. So they become very used to this and learn to live with it over a long period of time. That's 3 drugs better than 2. What about quads in transplant-ineligible patients? So the MROS trial, which we got a readout from at this year's ASCO, as I mentioned, randomized patients to get ISA-RVD or RVD, only 4 6-week cycles, triplet regimen or the triplet regimen in each group. Following that relatively short duration of quadruplet, patients continued their CD38 if they were randomized to that arm or they went on to RD doublet. So this study shows that adding a frontline CD38 to a triplet regimen in a transplant-ineligible population of patients also significantly delayed progression. I'll point out to you here that the 60-month PFS rate on the control arm of RVD is much higher than in any other trial. So I would be very cautious looking at the top-line PFS rate, comparing it to another trial, saying that's better and adopting this specific quadruplet. You have to look at the hazard ratio, which is spot on with every other CD38X versus X trial. So the overall survival data are immature. Remember, the 7-year OS on Maya is still above 50%. So we're not seeing a significant difference yet, but numerically, overall survival is favoring the quadruplet for this trial. What about benefit? What does adding bortezomib to CD38 RD get you? Well, this trial shows that bortezomib does still have some bang for the buck. About a little over double of the patients got MRD negativity at all of the relevant time points. And that's true in the overall population, the intent to treat population, and that's true for the subset of patients who are achieving CR. It's still a minority of patients that get to MRD negativity who get the quadruplet. Transplant, I think, is particularly useful getting to that time point. But keep in mind, the price that you pay for 1 in 5 patients getting MRD negative is 1 in 5 patients also getting debilitating peripheral neuropathy. Whether that's worth it is probably going to depend on an individual patient's goals of care and our fine-tuned clinical judgment about who's a candidate for risking more therapeutic toxicity. So conclusions on newly diagnosed myeloma management in 2024. Determination shows an ongoing meaningful progression-free survival advantage to patients who are eligible for transplant, and thus, in my opinion, autologous transplant remains the standard of care. I think the body of literature is sufficient to suggest that most patients should receive some kind of anti-CD38 monoclonal antibody as a component of induction. It's the remainder of the agents you give it with that should be modified. We know that quadruplet therapy, including an anti-CD38 monoclonal antibody, is superior to triplet therapy in terms of delaying progression for the vast majority of patients. But because of the toxicity associated with the proteasome inhibitor and its irreversible nature for transplant-ineligible patients, I would say omitting a PI is very reasonable. And then MASTER shows us that patients with a single high-risk abnormality, so this is many of our RISS3 patients, they do very well with these moderate induction strategies. So the new high risk may be folks with 2 high-risk cytopenic abnormalities. That's frontline. We've gotten a lot of updates. I'm going to move on to relapse. These are some of the questions that we've discussed previously. The one I'll draw attention to is early immune therapy, either with CAR-T or bispecific antibodies. This comes up a lot in frontline discussions. Patients often are eager to defer things like transplant for CAR-T or bispecific antibodies. I don't know which way the trials that are ongoing testing this question are going to shake out, but we're going to talk about the risks and benefits of CAR-T and bispecific antibodies quite a bit in the next 25 minutes, so I will leave it into the eye of the beholder whether the various disadvantages of those therapeutics are worth speculating about. All right, so with that in mind, we'll move on to relapse, a very dynamic area. So a 65-year-old gentleman with revised ISS1 myeloma diagnosed in 2018 initially got RVD, a transplant, and lenalidomide maintenance. He has no other medical problems. He develops new back pain and is found to have a new lytic lesion. His M spike is increased from undetectable 3 months prior to 0.6 grams per deciliter. You recommend this following strategy for relapse: daratumumab Pomdex, daratumumab KD, isatuximab KD, isatuximab PD, carfilzomib cyclophosphamide dex, BCMA-directed CAR-T, or other. I want to emphasize, I particularly think none of these answers are correct, or incorrect, I should say. All right. We got an optimistic bunch about immune therapy, which is very interesting to me. That wide group of people is reaching for that in a CD38 sensitive patient. Definitely not wrong and concordant with latest guidelines, but very interesting. Okay, moving on, another polling question. 65-year-old male, revised ISS1 multiple myeloma diagnosed in 2021, so only 3 years ago, got DARA-RVD, a transplant, and DARA-R maintenance through December of 2023. Since then, so just a few months, he's been on single-agent LEN, no other medical problems. Also is found to have a new lytic lesion, and his M spike is increased from 0 to 0.6 grams per deciliter. He has the same options for managing relapse the other patient had. What are y'all going to do? All right, 50-50 K-side-X or BCMA-directed CAR-T. And very few participants going back to a CD38 monoclonal. Okay, so the context for the early relapse myeloma landscape in 2024 is that now the vast majority of our patients that are relapsing have lenalidomide refractory disease. So a lot of the historical trials that we look at for relapse myeloma regimen, including those that involve CD38 monoclonals, enroll a relatively small number of patients that have lenalidomide refractory disease. So we're increasingly having to pay attention to subgroups, and some of the trials, such as Castor and Pollux, did not allow a lot of patients with lenalidomide refractory disease on. Got to focus on the subset of trials that looks at this lenalidomide refractory population. In those patients, the best outcomes are generally seen with the CD38-directed monoclonal-based regimen. So two things to combine with in a lenalidomide-sensitive population are carfilzomib and pomalidomide. We'll discuss the carfilzomib trials first. Two pivotal trials looking at this strategy were the Candor and IKEMA trial, both with the carfilzomib and dex control arm, patients being randomized to receive that plus or minus daratumumab or isatuximab for Candor and IKEMA respectively. Both trials allowed 1 to 3 prior lines of therapy, median of 2, and about a third of the trial populations on both trials were lenalidomide refractory. Benefits that are seen are preserved across that subgroup, but keep in mind that only a third of the patients on these trials, which establish a relative standard of care in that population, actually had len refractory disease. So both trials show a meaningful improvement in progression-free survival with hazard ratios that are nearly identical. So adding daratumumab to carfilzomib and dex alone delays progression by nearly double in both Candor and IKEMA trials. Probability of achieving MRD negativity also goes up by 15 to 20% in both studies. So adding a CD38 to a CD38 sensitive len refractory patient has real benefit if you're going to be using carfilzomib along with it. What about our patients with cardiac disease who don't want to go to the infusion center at least once a week? By the way, I'll also note that on both of these trials, carfilzomib was given twice weekly. Hard to counsel patients to expect the same PFS on the treatment arm, getting a little less carfilzomib, which most of us do. But patients that don't want to regularly visit the infusion center or who can't get carfilzomib, what about pomalidomide? Well, there's 2 pivotal trials with CD38 monoclonal antibodies plus pomalidomide and dex in early relapse as well. These are Apollo and Icaria, both of which look at PomDex plus or minus a CD38 monoclonal antibody. Apollo for Dara, Icaria for isatuximab. They do have somewhat divergent populations of patients, unlike Candor and IKEMA, which are nearly identical. Icaria mandated patients have 2 prior lines of therapy, so they were a little more heavily pretreated. Lenalidomide refractoriness was more universal in the Icaria trial than the Apollo trial. However, more patients were proteasome and more patients were proteasome inhibitor refractory on the Icaria trial. So a little bit of a sicker and more heavily pretreated population on Icaria than Apollo. So keeping that in mind, what we see when we add daratumumab or isatuximab to pomalidomide and dex is around doubling of the median progression-free survival to a period of about 1 year. Very much concordant with real-world data looking at how patients do with CD38 Pomdex in this setting. So individualized discussion if you're going to use a CD38-based triplet in relapse, whether potentially delaying progression longer is worth all the infusion center time and toxicity of carfilzomib. So these are the trials for the patients that are CD38 sensitive. We've discussed that the Perseus trial, if you're going to follow it to the letter, involves 2 years of daratumumab maintenance after transplant. We've also discussed that the Maya trial involves indefinite CD38 monoclonal antibody treatment. So many of the patients who are relapsing either will have very recently seen a CD38 monoclonal antibody or will be progressing on it. So can you apply these data with CD38 monoclonal antibody-based regimens to CD38 refractory patients who were excluded? The answer is no. So early relapse strategies for LEN and CD38 refractory disease are sorely needed, and a lot of the data we're going to discuss is going to cover those patients. So historical standards not including CD38 monoclonals. So these are regimens that don't use bispecific antibodies or CAR-T. Selinexor-VD, the Boston regimen, did not report on any patients with the CD38 monoclonal antibody and only has a 10-month PFS in LEN refractory patients. PVD, also, the Optimism trial is older and enrolled before CD38 were FDA approved. Does have a bit of a longer median PFS in LEN refractory patients, unknown what it would be in the more difficult CD38 refractory population. Eloquent 3, ELO-PD had 3 patients with the prior CD38 monoclonal antibody. We know from other high-quality retrospective work that outcomes for patients getting ELO-based regimens after daratumumab specifically failure are poor. And then cyclophosphamide-based triplets, a variety of randomized trials call into some question whether adding cyclophosphamide has any benefit. So I would say none of these strategies inspire much enthusiasm for patients that are refractory to lenalidomide and CD38 monoclonal antibodies, in my opinion. So this is an intriguing place for CAR-T to enter. So chimeric antigen receptor T cells, or CAR-T cells, are T cells that are genetically modified to express a chimeric antigen receptor against the tumor-associated antigen. So this cartoon shows a CAR that's directed against the B-cell maturation antigen, which is nearly universally expressed by myeloma cells. And so the idea is that the CAR construct, which contains a variable fragment targeting the tumor-associated antigen, a co-stimulatory domain, and a CD3 signaling domain to sort of hype up the T-cell cytotoxic function, can result in rapid and durable toxicity to myeloma cells. So the KarMMa-3 trial is a phase 3 trial that involved 2-to-1 randomization to ide-cel, which is a BCMA-directed CAR-T cell, and one of a basket of investigator choice regimens. So DARA-PD, ELO-PD, KD, ixazomib Lendex, or DARA-VD. I give you those in descending order of how frequently they were used. Many patients got DARA-PD. Median 3 prior lines of therapy, so most of these patients were earlier relapses, and the vast majority were refractory to an IMiD and to daratumumab, with 66% being triple-class refractory to a CD38, an IMiD, and a PI. This trial showed a very dramatic improvement in progression-free survival associated with using CAR-T in this setting. Many of us were hoping for ide-cel to dramatically improve on its median PFS in later lines of therapy. Unfortunately, it did not, as a 1-year median PFS here, as it does in patients with 4+ prior lines of therapy. I think the striking thing about this trial is, to me, the standard of care, which is a pretty representative series of options compared to what we did before CAR-T entered this landscape, only has a median PFS here of 4 months. So definitely a sore unmet need to improve outcomes in this population. All the various response steps got better with CAR-T early compared with the typical early relapse regimens that were used in the control arm. CARTITUDE-4 looks at ide-cel's kissing cousin cilta-cel, which is another BCMA-directed CAR-T. This trial randomized patients to an investigator's choice. All patients got pomalidomide. They either got DARA-PD or PVD. Patients here were a little bit earlier, so less heavily pretreated than the KarMMa-3 trial, 1 to 3 prior lines of therapy, median 2. And then notably, a number of these patients were not CD38 refractory. So this is a key reason why you can't dance the PFS dance across these trials. We all know in this state that if Duke beats UNC and UNC beats NC State, it doesn't mean Duke is going to beat NC State. So dancing across trials is comparably difficult to do here. And the reason comparing CARTITUDE-4 and KarMMa-3 is that not even a majority of patients are CD38 refractory on CARTITUDE-4. With that said, early CAR-T here also improved progression-free survival. I'll note that the curves actually cross around 3 months. There were some patients who progressed while awaiting CAR-T. So a real issue that we have is that some patients' disease is relapsing too aggressively to adequately bridge them to CAR-T. Some patients also, unfortunately, do pass away from therapy-related mortality with CAR-T. Depending on the trial, it's 3 to 5%. However, after a few months, that comes out in the wash, and you see a significant advantage in progression-free survival for patients getting cell-to-cell. Notably, the magnitude of the benefit is preserved in the small number of patients that were triple-class refractory, only 15% of this population. What about the functionally high-risk group? These are people that we think have a really strong unmet need for CAR-T, people that do especially badly with non-CAR-T strategies. So patients that progress within 18 months of a non-transplant strategy, I think it's 24 months, that's a typo there, of transplant, if transplant's done. Those patients also did derive a meaningful benefit from earlier CAR-T, with median PFS not reached in the functionally high-risk population at over a year of median follow-up. What about safety? We're going to get into CRS and ICANS a little bit later, not much later because we don't have a lot of time left. But these benefits in progression-free survival came with some risk of getting cytokine release syndrome, usually grade 1, which means it gets better with Tylenol. But some grade 3 cytokine release syndrome and neurologic toxicity, both with cilta-cel and ide-cel. Single-digit percentages, but potentially very serious and merit very close monitoring. What about patients that can't get to a transplant center for CAR-T? Many of you will be familiar with belantamab mafodotin, or belamaf, which is a BCMA-directed antibody-drug conjugate. That was taken off the market due to a negative registrational trial, and very likely will be coming back soon because of 2 positive registrational trials that have since come out. These are the DREAMM-7 and DREAMM-8 trials. DREAMM-7 was in CD38 sensitive patients, therefore not that relevant, so randomized patients to Bela-VD or Dara-VD. DREAMM-8 randomized patients to Bela-Pomdex or PVD, and did get a good number of patients that were CD38 refractory. Both of these trials show that the belantamab-based triplets resulted in improved progression-free survival. The hazard ratio in the CD38 refractory patients is a little bit higher. Just a little bit, not surprising because that's a higher risk population of patients, but merits attention on subsequent follow-up, whether the confidence interval of that crosses 1. So a little bit of uncertainty on how effective this is in a Dara refractory patient, but still encouraging that in the overall population it delayed progression by a good amount. Overall survival also numerically favored belantamab in both of these studies, although the effect was stronger on the DREAMM-7 trial than the DREAMM-8 trial and reached statistical significance. So in conclusion, CD38 monoclonal antibody-based triplets remain the standard of care for patients who relapse on Revlimid. BCMA-directed therapy should be considered for patients with early relapse who are Len and CD38 refractory. CAR-T for patients that can get to a CAR-T center, but the belantamab-based triplets should be available soon for ineligible patients and offer an opportunity to target the BCMA in the community. Questions? Are bispecific antibodies going to play better here? We don't know. We don't have mature trial data to discuss yet. Combination therapy with bispecifics and any of the other active drugs, worth the risk? Need randomized trials to know. And then there are novel classes of therapy, such as other ADCs and cell mods that are being investigated here as well that I'm going to be paying close attention to in coming years. All right, we're going to get to later relapse. I'm going to try and do this justice in 7 minutes. 68-year-old male has a history of revised ISS2 myeloma dating to 2017. He had RVD transplant and Len maintenance, relapsed in 2020. Dara-VD started upon relapse. That worked for a year. He got carfilzomib Cidex, worked for 2 years, and then he's now progressing on selinexor Pomdex. So refractory to Revlimid, bortezomib, Dara, carfilzomib, and Pom. Over the last 6 months, he's had a biochemical relapse. He's asymptomatic, no new lesions. Your recommended management is isatuximab KD, cilta-cel, ide-cel, teclistamab, talquetamab, elranatamab, bendamustine, or other. Interesting. Okay. We've got a lot of people who want to give this patient a bispecific antibody. I don't think there's a right answer here, but I would too. Okay, so how do we manage later relapses without immune therapy? Well, the answer is the approaches that exist result in pretty grim outcomes. Selinexor Dex, minority of patients respond, and the median overall survival is under a year. Bendamustine, we don't have great data, but works about half the time, and when it works for about 6 months, very concordant with real-world practice. High-dose Cy, difficult to give, requires hospitalization, and does not perform well either. And then belantamab mafodotin, which we've just discussed and technically is not available yet, does result in median survival over a year, but still only works in a minority of patients. So this is where the bispecific antibodies really excite me. So these are similar to CAR T cells, harness the power of the T cell to fight cancer. And these therapies are T cell redirecting therapies with 2 arms, one that targets CD3, which is a T cell antigen, and another that targets a tumor-associated antigen. So this cartoon shows teclistamab, which is BCMA and CD3 directed antibody. So there are subtle differences in structure, which result in divergent toxicity and efficacy, but a theme that emerges is most of these that are being investigated have similar toxicity and efficacy. All right, so we talked a little bit about cytokine release syndrome. What is it? It is an acute systemic inflammatory syndrome characterized by fever and multiple organ dysfunction that occurs after CAR T or antibodies, including bispecific antibodies. Grade 1 is characterized by fever alone without hemodynamic complications. Grade 2 hemodynamic complications are basically things that can be managed on the floor with supplemental oxygen and and no vasopressors, so just fluids. Grade 3 is requirement of some ICU level of care. Grade 4 is requiring multiple pressors and or mechanical ventilation. Grade 5 is obviously fatal. So that's when we talk about grades of CRS, that's continuum is important to keep in mind. What about ICANS? Obviously quite a bit more serious in most cases. So this is a neuropsychiatric syndrome that occurs in patients treated with immune therapy, is essentially characterized by deep depressed level of consciousness, which increases with increasing grade of neurologic toxicity. I show these, only to point out that a patient with grade 2 ICANS is somebody who's not getting most of the questions on the right correct, and a patient who's only awakening to voice. That is a very sick patient, even though the toxicity is grade 2. So when you're digesting trials, important to pay attention to the grade 2 ICANS rate. That is a very sick patient and worth giving a hairy eyeball to taking that risk. This is how you manage ICANS. Grade 1 often is managed supportively. Grade 2, patients get dexamethasone. And then for grade 3, ICU level of care is recommended. In practice, we often do that for grade 2 because usually there's other things going on there that make patients quite sick. All right, comparing CAR T to bispecific antibodies in this space. What are the advantages and the disadvantages? So CAR T requires apheresis and ex vivo modifications. So when you think that a patient needs CAR T, you're waiting a minimum of 8 weeks before it's getting in vein, probably longer. And sometimes apheresis slots can be quite limited. Bispecific antibodies are available off the shelf and don't have as many access restrictions. CAR T a little more effective in general, but the overall response rate for bispecifics is generally greater than 50%. Toxicity, I wouldn't say is better with bispecific antibodies, it's just different. So a little less likely to get severe CRS or ICANS, but more likely to get, in the case of a BCMA-directed bispecific antibody, an infection, which is the primary tumor antigen-associated toxicity. And in the case of talquetamab, which targets a different antigen, has some different toxicities. CAR T and later relapses of myeloma, ide-cel and cilta-cel, which we discussed previously, both entered the landscape first for patients with later relapses. Contrasting that with what we saw all the way back here, where most patients did not respond to the non-immune therapy-based regimens, we see a significant majority of patients getting responses, most of which are quite deep. And then deep also translates to durable. Median overall survival not reached over 3 years of follow-up with the CARTITUDE-1 trial. And then a lot of CRS and ICANS, but most of it is relatively low grade. ICANS grade 3 rate of 12% with cilta-cel is real and gives me real pause with moving it earlier in all patients. So these are these are single arm trials. So these are just curves showing the same thing. Majority of patients haven't progressed by 1 year, a little under 1 year on ide-cel, and a little over 2.5 years on cilta-cel. What about bispecific antibodies? So we'll first talk about teclistamab, which is the first one to enter the market. That one is given by a complex step-up dosing paradigm where patients are given escalated doses at 2 to 7 day intervals, culminating in a therapeutic dose 4 to 6 days after initiation and ongoing weekly administration. 60% of patients get a response, the majority of which are very good partial responses or better. In the overall population, the median PFS is 11 months, and in responders, the duration of response averages to 18 months. Waterfall plot here shows that many of these responses deepen over time. So not all patients are in their best response at 1 month after teclistamab. Many get there later. What about elranatamab, which is another BCMA-directed bispecific antibody that's FDA approved? That is a little bit of an easier step-up dosing paradigm where patients get a priming dose, a dose at day 4, and then subsequent weekly doses starting at day 8. So there's like a missing dose in there. Observation can be truncated according to updated labeling to 24 hours after dose 2. Similar response rate and duration of response to teclistamab. So these drugs, even though their chemical structure is different, both result in pretty similar outcomes. What about the highest risk patients? So people that are relapsing very aggressively, have high risk cytogenetic abnormalities, or have other high risk features, including extramedullary disease and high burden of disease. In many of these populations, teclistamab retains its efficacy. So people with pentarefractory disease, people with high risk cytogenetics have a similar probability of a response with teclistamab to those that don't have those high risk features. Where these drugs don't perform as well are in patients with extramedullary disease, where the overall response rate is under 40%. Still an improvement over things like selinexor and belantamab, but worth keeping in mind when you have a high-risk patient with a later relapse that they might not expect the same outcomes here as with other things. More data showing a similar theme. What about patients that have had prior BCMA-directed therapy? Those that have had a prior CAR T or ADC have a slightly lower probability of a response to teclistamab. The key here is that the overall duration of response is meaningfully shorter. And the probability of response of significant depth like CR or VGPR is somewhat lower. So treating with teclistamab after BCMA CAR T works, but does not work as well. Big toxicity of this class of drugs is infections. Significant probability that patients get grade 3 infections on teclistamab. Over 50% of the patients on the Majestic-1 trial, which led to this FDA approval, did get some kind of grade 3 infection. This is emerging data that shows a powerful benefit to IVIG in reducing the probability of infection. So meaningful reductions in all grade and grade 3 infections in this retrospective analysis of patients getting IVIG. Lastly, I'll talk about talquetamab, which uniquely has a different target of GPRC5D. It has a more complicated step-up dosing schedule, so has 3 step-up doses instead of 2. Carries a similar overall response rate of about 60% in a very heavily pretreated population. And unlike the BCMA-directed bispecifics, results in a relatively low rate of infections. However, this drug is really difficult to give because it results in oral toxicity and weight loss in a high percentage of patients. So the median patient loses something like 5% of their body weight, and it can take a really long time to recover, although in the long run, many patients do get used to the taste toxicities that are associated with this drug. So a difficult drug to give. Definitely, I tend to save it for later because of this weight loss and oral toxicity issue. It has some other toxicities that sometimes can bother patients, can cause skin issues, rashes, can cause nail dystrophy. So those are also bothersome for a minority of patients, but really for most people, it's weight loss and difficulty with taste that limits using this drug. So I like it for high-risk patients, for patients that have exhausted other options, but definitely not the easiest drug to give. One final word, I've talked about high rates of infections with these bispecific antibodies. So as you can see, it's not like, the triplets have a free lunch. There is a real therapy-related mortality associated with the CD38-based triplets, specifically because of infection between 2 and 5%. So keep that in mind when discussing the probability of severe infections with bispecific antibodies. My opinion, the infectious signal very real. With IVIG, we're making it better. The way that concerns me is that these drugs might not be as combinable as we'd previously thought. Okay. So in conclusion, both CAR-T and bispecific antibodies show consistent superior efficacy to non-T-cell engagers. Although there's promising efficacy, there are major challenges. Patients need to be monitored for CRS and ICANS. We need to get better at preventing infection, although IVIG is really important and efficacious. And then we need to get better at managing the oral and skin toxicities of talquetamab. Sorry, I'm a little bit over.
That is quite all right. You had a phenomenal amount of information to share. Thank you so much. Just time for a couple of questions. One here, I believe you stated the greatest unmet need in myeloma therapy is stopping myeloma therapy. If you can elaborate on that, please. Oh, you're muted, Dr. Rubinstein.
Sorry. Yeah, patients with myeloma are generally, the standards of care are generally to treat these patients more or less indefinitely. I showed that MASTER, which is a single arm trial, suggests that many patients can have long PFS and OS without staying on therapy forever. We need to prove that therapy is not inferior, that stopping therapy is not inferior yet to keeping people on indefinite therapy. Nobody loves coming to the infusion center indefinitely. Even Revlimid obviously isn't the easiest drug to take in everybody. So we need strategies that we can develop in myeloma that involve stopping therapy so people can get back to living their lives.
Great. Thank you so much. And can you touch on the use of CD138 plasma cells in assessing disease?
Yeah, so CD138 is a universal biomarker of plasma cells, so it's expressed by most normal plasma cells and most myeloma cells. Often gives you a little bit of a more robust idea in the bone marrow of just how much of the bone marrow is involved by myeloma. We do have a phase 1 trial actually involving a CD138-directed chimeric antigen receptor T cell. That's an in-house study led by my partner, Sasha Tuckman. So CD138 may have therapeutic efficacy in addition to being a pretty specific biomarker for a abnormal plasma cell. So for patients that have exhausted commercial options, that's a phase 1 trial. So for people that have commercial options, not a great option. But people that are running out of options, consider sending them to us to think about that study.
Great. And we'll take this final
Are we
question.
going towards...
Oh, go ahead.
Yeah, sorry, you go ahead.
Oh,
so it's a great question.
Okay, go ahead.
It's a really good question. I don't think we know how to dose teclistamab properly. The label is being updated to allow Q2-week dosing starting after 6 cycles of therapy for patients that achieve a VGPR or better. That may be too much. There's recently published high-quality multi-center retrospective data from my colleague Raj Chakrabarty at Columbia that looks at a minority of patients who stopped teclistamab due to side effects, mostly infection. And even stopping teclistamab, the majority of patients in his cohort study continue to respond. So there may be some residual sort of T-cell priming that happens after patients get bispecific antibodies that results in delayed and preserved efficacy even after the drugs are categorically stopped. So I do think there's a lot of potential legs towards transient administration of bispecific antibodies, certainly stepping out the dose as the questioner suggests. Probably would be better to have more hard data than just anecdotes and retrospective studies. So ongoing investigator-initiated and other trials addressing this question are planned, and some are accruing patients, and I'm very eager to see if less frequent dosing preserves efficacy. I think it probably will, but that's my vibe, not my scientific opinion yet.
Understood. Thank you. A couple of closing remarks. We do want to thank the people of North Carolina for their funding through the state of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. We want to thank Veni Obore, John Powell, Oliver Marth, Andrew Dodson, Patrick Muscarella, and Barbara Walsh for all of their hard work on each and every one of these lectures.